Okay, I think for the benefit of those that join on time, we will get started, please. We have close to 100 people participating, and as you can hear, a lot of more people coming. If you can hear the clicks, we can hear the clicks from here. In any case, let us start it and welcome you to this webinar that the focus is system transformation, welcoming and supporting care coordinators. We are not going to hear that all of you attending are care coordinators, but to those of you that are care coordinators, a special welcome, because we hope that some of you at least were able to join us in 2012 when we did the consultations for our document enhancing community care in Ontario, or ACO, which, as you know, the minister referenced heavily on his Patients First report, and wherever he speaks, or the deputy, they share how much ACO influenced the thinking of government. And by that I mean not only the current minister, but also past minister, the premier, and opposition leaders as well. So it's a document that has been highly influential, and we feel very proud about that, and we thank those of you that provided feedback, and especially I want to give a special thank you to Shanique, that also participated very heavily in shaping the public health component of that document. Family practice nurses also participated, and they are here joining today. So with me here at our NAO office is myself, Doris Greenspoon, CEO of our NAO, Daniel Lau, Director of Membership and Services, who will share with you about how our NAO support you, Tim Lenartowicz, Director of Nursing and Health Policy, and I will share in a minute how we will join the presentation. Joanne Crawford, who is the chair of SHINEC, Community Health Nurses Initiative Group, Ina Howard, who is the chair of the Ontario Family Practice Nurses. We will first share with you a bit of history and context in relationship to how our NAO sees the system evolving, and then we will move right there into the ACO model to remind you, some of you are very familiar, but how our NAO at the time in 2012 presented the health system transformation to government, and then in 2014 again. Then Tim Lenartowicz will go through Bill 210, which creates the legislative framework to transfer and dissolve CCACs as structural entities, and he will share with you the implementation phases and the recommendations that our NAO has put forward. Following that, we will share also how we see the caseload for care coordinators, which we believe will be an important aspect for you. And after that, we will open for 10 minutes or so of questions on the policy issues, on our NAO's views, and also on other aspects that you may want to share, or you may want to discuss with us further related policy aspects, which we will do either today or we will set up a second webinar to gather your feedback. We do want to leave at least 20 minutes for Daniel, for Joanne, and for Sheena to speak about our NAO's membership and services, and how we can support you, both from an education perspective, from a simple collegial perspective, and of course from the PLP, professional liability protection. So Daniel will take 5 minutes or so, and Joanne will take 5 minutes, Sheena will take 5 minutes, and then we will open again for questions. We have now well over 200 people, and obviously people will continue to join, and at some point we may again, as we speak, introduce ourselves so people know where we are within the presentation, and if they join a lot later, what they have missed so they can join a future one. So we know that Ontario is really on the cusp of significant health system transformation, which we hope will optimize health service delivery. And we say we hope because obviously all the pieces that need to be in place, including health human resources, need to be there to deliver on the promise. Our NAO has identified the opportunity to provide clarity to CCIC care coordinators as the process unfolds, but also to any nurse, whether RN, nurse practitioner, RPN, or nursing student that wishes to understand the next steps and also the legislative changes, as well as wishes to provide us feedback. So we will provide, as I said, historical context, what our NAO envisions as next steps, and an overview of membership services, including 2 key RNAO interest groups, which are not all, of course, but we believe are the 2 most relevant to this presentation. So the key principles for a high-performing team, in our view, are interprofessional primary health care that anchors the system. We do not believe that the health system, and this is not just us, but the evidence of all the OECD countries, a system cannot be foundationally anchored in hospital care. Not that hospitals are not important, they're very important, but in the future they should be important for really the more complex and more sick individuals, and a health system should be anchored in primary health care. Accessible and person-centered and adequate and appropriately utilized workforce is key to delivering on these promises, and that's, by the way, where we're falling short at this point in terms of health human resource planning. And although not the matter of this presentation, we do have webinars and have had several webinars on the topic of our latest report, the Mind the Gap in Health System Transformation, Reclaiming the Role of the RN, which, by the way, is not because it's focused only on RNs, because it actually speaks about RNs, RPNs, and nurse practitioners, but where we fall short in the country and in the province at this point is on the RN file, and in fact we are the lowest RN per population in Canada. That's not what we will focus today, but watch the website, Mind the Gap report. Those are webinars you may want to attend if you want to hear more about health system transformation. And then we do believe very strongly, and this is not only RNAO, but any entity that is involved in primary care and in high-performing systems knows that care coordination must happen in primary care. Let me review with you the timelines so you understand the impact and influence of RNAO. In June 2012, RNAO issued a report, Primary Solutions for Primary Care. Again, some of you may have been involved in consultations. The key stakeholders in terms of outside of RNAO also that were involved, included the OMA, the Ontario College of Family Physicians, NPAO, the Ontario Family Practice Nurses Interest Group, RPNAO, et cetera, many groups, both within nursing and outside of nursing, that were involved in shaping with us the Primary Solutions for Primary Care, which was a provincial report. Following that, in October 2012, we issue ACO 1.0, which, as every good report will do, raised a lot of debate. It was a major health system transformation that RNAO was proposing. You will see in a few slides the diagram that we put. And basically that report said primary care needs primary health care needs to anchor the health system, and everything else should be moving around patients that are anchored in primary health care. In December 2012, the government launched, and by the way, you do need to know that these reports were discussed with the three parties ahead of release, and then, of course, after release, and both Primary Solutions to Primary Care and ACO received lots of support from all three parties. In December 2012, the health links were launched by government. In April 2014, given that still we had not moved sufficiently to primary care, we issue ACO 2.0, and in that report we also issue an addition, which was an enriched aspect of public health thanks to Shanique involvement, and also we issue a transition plan for labor management where the government follow on ECHO report. On October 2014, the Ontario Primary Care Council, which we are part of alongside with OMA, Ontario College of Family Physicians, pharmacists, and others, issued a statement on care coordination where they unanimously came to the agreement that care coordination must happen in primary care. Then in March 2015, the report of Home and Community Care report, again, put a lot of emphasis on how communities should evolve. In May 2015, the minister accepted the panel recommendations, and then in September 2015 and in December 2015, two very, very damning Auditor General's reports that spoke about the cost and lack of deliverables of CCACs as a structure. So this was not that the functions of CCAC were not required, but the structure itself was problematic in how expensive it was and the level of expenditures that went into administration versus patient care. Let me clarify, our NAO has included those auditors' reports in our own recommendations. We are very clear when we speak about the layer of administration that we are not referring to care coordination, because in our view, care coordination is essential. The question is where care coordination can happen best and who can deliver care coordination, which we remain firm that it is the care coordinators that are currently working in CCAC that should have first priority to be located in primary care to deliver care coordination to complex patients alongside their colleagues that are already working in primary care for less complex patients. May 2016 comes to mind the safety gap in health system transformation, and it's when we review the government's Patients First discussion paper that was released on December, if you remember, we realized that although we agree with most of what the minister says, he fell short on integrating public health, and also there was absolutely no discussion about health human resources planning, and that concerned us greatly, and hence why we worked on a report and released it on May 2016 this year. In June 2016, Patients First Act is introduced, and Tim later on will discuss the act and what it proposes. So RNAO has consistently been at the forefront of influencing policy. This is no surprise to any of you. We have done that, whether it is on social determinants of health, on environmental determinants of health, on health human resources, and yes, on health system transformation. You are very engaged, those of you that are already RNAO members, in providing feedback, in participating in consultations, in action alerts, et cetera, and thousands of members are engaged, and we cannot thank you enough and do that generously at every occasion that we can, and this is one more occasion to do that. RNAO was pleased to have been recognized by Health Minister Hoskins at our 91 AGM in May 2016, having heavily informed much of the reform agenda. Not only he thanked us verbally, but he also referenced the report in his own Patients First report. Let me go very quickly through the ACO model and what the ACO model entails. So basically, first of all, we believe that any health system needs to be person-centered with universal access and with timely access to health services. Hence why in the center circle you see person-centered access with patients and family councils there at every single location in the lanes at least, so that they can inform an agenda that is focused on people and not only on health professionals. Not that we are not important, but if we do not respond to people's needs, then what are we here for? You also should look at the outer square where it says the 4 areas that we believe the system needs to put a greater emphasis. And we are speaking about health promotion at the bottom. This is prevention, because health promotion is foundational, disease prevention, and then the 2 sides, which are chronic disease prevention and management, and mental health, which we keep talking and talking and talking, but the system has done insufficient work in our view in focusing on that. Then you see primary care, which is bold, and it's because we see that as the key linkage to people and the system. So you see then dotted lines between primary care and long-term care, primary care and acute care, primary care and specialty care, primary care and healthcare providers, specialties and home care, support services, and public health. Let me a little bit speak about this so you understand how we see the role of care coordinators evolving. Right now, care coordinators are, in our view, on a sideline in community care access centers. Their role is hugely, hugely valuable and important, but they cannot influence ongoingly the system because they are sent to people's homes or to people's lives at moments of needs, not ongoingly. So they're not anchored within a health team that knows that person from beginning to end of life. That's why we believe that care coordinators, and this is what we propose to the government, that care coordinators, those that are already working in acute care, be hired by the hospitals to become the system discharge planners, as we used to have many, many years ago, right? And then we see the great majority of care coordinators that are not in hospitals, about 90% of those that are care coordinators, most of them, by the way, are RNs, but also from other disciplines, moving into interprofessional primary care sites and working within interprofessional teams to provide care to the most complex patient population, and to also serve those solo doctors that when they go on vacation or they go to a conference or they're ill, etc., do not have anyone to attend these people. So we see some of these interprofessional primary care sites to be subcontracted by solo doctors to provide interprofessional care that people need, or to cover for them while on vacation or absent for whichever reason. And instead of people going to an emergency room, they will go to this close by site to receive interprofessional care from expert teams. We believe that this will provide increased access, person-centeredness, improved quality, improve outcomes for patients and for their experience in the system, health system integration, which right now we hardly have, and cost effectiveness for the system. So let's move to what's next, and let me ask Tim Lenartowicz, Director of Nursing and Health Policy, to go through Bill 210 and share with us the thoughts that we have here.
Great. Well, thank you so much, Doris, and good afternoon to you all. It's great to be able to reconnect with many of you. I've been pleased to, over the past several years, have had the opportunity to connect and hear from literally hundreds, if not thousands, of colleagues within primary care and within CCAC specifically, including care coordinators. So to give you a bit of a background on Bill 210, when you think of legislation, it's, I think, helpful to consider it as in the context of a home. And so legislation really is your foundation upon which something is built. And so Bill 210 does create the legislative framework to transfer and dissolve CCACs as structural entities. The bill itself actually amends a number of other pieces of legislation. Largely, it repeals the Community Care Access Center Corporations Act, and significantly broadens the Local Health Integrations System Act. But again, the legislation very much serves as that foundation, and so much of the work to make the change happen is going to happen through complementary policy changes. And so that, I guess, again, going back to that analogy of the house, if you have the legislation as your foundation, the policy is then what you build upon. But that being said, in order to get good policy, you also need to have and ensure that you have good legislation. So RNAO is doing a very thorough analysis of the bill, as we do for many bills that are before the legislature, and we will have a comprehensive response. So what I'm providing you right now are more preliminary and high-level comments. And the first is that the bill does provide for a transfer of CCAC care coordinators to become employees of the LHIN. Now, this is not within the bill itself, but again, it's a complementary policy area. We know that there's a high likelihood that the care coordinators will be located within primary care, and that comes from the Patients First discussion paper that was released in December of last year. Now, where RNAO would have some caution is around the role of LHINs in direct service delivery. And again, LHINs were structured and set up to be able to fund, hold accountability agreements, evaluate and monitor a local health system, not to deliver services directly, and therefore we do have some concern with the legislation and specifically the service delivery role of the LHIN. Rather, we see the services being delivered and coordinated through primary care and through home health care and support service organizations directly. And I think Doris has something to add.
So to add to this, we have no issue, and we have informed government that care coordinators be employees of the LHINs. And that is important at this stage at least, so that you protect your unionized rights for those of you that are unionized, which is most. So the pay comes from the LHINs. You are employed by the LHINs, but you are located in primary care and providing the service in the context of an interprofessional team that knows the patient from beginning to end.
Yeah. Thanks, Doris. Another caution that RNAO has in relationship to Bill 210 has to do with the role of our public health. And in the Patients First, the discussion paper in December 2015, there was a proposal to have public health come within the LHIN mandate. And what we're seeing in Bill 210 is a greater alignment of public health with the LHINs, but not actually having public health units within the LHIN mandate. And we feel that that will fall short in providing health system integration, and particularly being able, missing the opportunity to fully embrace and utilize public health across the health system and bringing greater attention to social and environmental determinants of health, community mobilization, and community engagement. A couple of areas, in addition, that we're quite encouraged with Bill 210 include the requirement that LHINs will now have patient and family committees. Going back to ECHO, this is something that we called for, having the patient-family councils is what we called them. So it's encouraging to see that within the LHIN structure. And then also expanding the LHIN mandate with a greater emphasis on the social determinants of health and health equity. Particularly the clause that's added is that the LHIN is required to promote health equity, reduce health disparities and inequities, and respect the diversity of communities in the planning, design, and evaluation of health services. So next slide. So in terms of RNAO's recommendations, this was provided in our comprehensive response to the Patient's First discussion paper in March 2016. And so we recommended that the province moves forward with substantive health system transformation, including the true realignment of CCAC functions and services within existing areas of the health system. And again, this is completely consistent with ECHO. We're calling for the location of the 3,500 CCAC care coordinators within primary care organizations through a secondment. And this goes back to what Doris said in terms of having the LHIN, again, serve as the employer, but having the care coordinators located within primary care. And also we're calling for the development of provincial standards for care coordination and health system navigation. So in this, these changes will produce savings to the health system, but we are calling for those to be reinvested into service provision with a focus on increasing the hours of home health care and support service delivery, as well as mental health and addictions care. We've calling for the mental health nurses in schools to be transitioned into public health units, as well as into the mental health sector, and transitioning nurse practitioners into primary care and home health care and support service providers. We've also called not for an automatic transition of CCAC executive positions to the LHINs. This is not in any way connected to the people who occupy those positions, but rather it is taking an objective look at the system and ensuring that we are able to effectively utilize the resources that we have. And so first, transitioning functions to the LHINs and other areas of the system, and then doing an assessment in terms of what additional gaps there are and filling those gaps as necessary. So the next slide has to do with in terms of implementation. So I talked about the legislation really as the framework of the House, and so much more of moving forward is going to depend upon policy. And so in terms of implementation, some things that we've gleaned from the Patient First discussion paper are that CCAC employees providing services to clients would be transitioned to and employed by the LHINs, that home care coordinators would be focused on LHIN sub-regions and may be deployed into community settings. This is all language directly from the government. Home care services would continue to be provided by service providers, and that over time these contracts would be better coordinated and consistent with geographic models of the LHIN sub-regions, and that the LHINs would be responsible for LTC placement that's currently administered by CCAC. And again, I just want to emphasize that RNAO's recommendation is that the care coordinators will be located within primary care. Throughout the entire experience since 2012, we've talked about ensuring that care coordinator salary and benefits are maintained, and certainly the secondment model would be a very effective one within this context. So next couple of slides just were informed in consultation with CCAC care coordinators, and they help to provide a depiction about, well, what does all of this look like? So you're saying that we're locating care coordinators within primary care. well, how would that actually be operationalized? And so in collaboration with the care coordinators and with primary care as well, we did develop a visual schematic around what this would look like. And this is contained and available online in our response to the Patients First discussion paper. And it really positions CCAC care coordinators who have the expertise and knowledge in care coordination and health system navigation to be able to provide, coordinate service delivery for those who have very complex needs. And it enables you to fully utilize that, because I've heard in speaking to many CCAC care coordinators the limitations that are currently present within the system. And it's not because of a lack of competency or interest, but rather your hands are being tied and you have a very difficult job. You understand this is what the person truly needs, but unfortunately because of resources you aren't able to necessarily get them the full amount of service, let's say, that they require, or focusing on coordinating specific services in absence of a broader coordination of service. And then the last point that I want to raise before we pause for questions on the policy pieces, we've also come up with a sample care coordinator role description that, again, aims to fully utilize your knowledge, skill, and competencies. You are experts in care coordination, and we feel that if done properly in this renewed health system transformation, that this will enable you to fully utilize that knowledge and skill in being able to provide person-centered services. So that is a very high-level overview, and why don't we open things up for any questions?
So 2 things we will do now. Josephine will explain how to share questions, and she also will put, meanwhile, that she explains the slide on our NAO vision for system effectiveness, so that we can tie kind of all the reports and you can understand how do we function in our minds when we are developing these reports. So Josephine, maybe you first, and then I can explain very briefly this.
Sure. So if you're logged into the WebEx interface, you'll notice that on the bottom right corner there's a chat box. If you have any questions or comments, you can type them there and submit them, and I can read them out on the line for everyone. And I can also put them up on the whiteboard for you to see as well.
Fantastic. Thank you, Josephine. And if you, by any chance, want Josephine to repeat the instructions, just shout out, tell us a note, please repeat the instructions. But we will start to get questions. But let me, as you write questions, explain for a second this diagram. So consistent with other aspects and other reports, we have said ongoingly that timely access to universal quality care that is person-centered is at the very foundation of anything CareNAO does, really. We believe on, as you know, universal access to health care. We believe that in order to be sustained, it's to be timely, and we believe that it must and it can deliver both quality care and person-centeredness. We see 4 pillars for this to happen. We see the pillar of health human resource planning, and as we said to you, we believe that the Persons First initiative or Patients First initiative of the Minister falls on that, and hence our ongoing work on health human resources is not new. Every single year we have been warning that we have dwindling numbers of RNs and that they are being replaced with less qualified providers. Mindful that other providers are valued, but with the health system transformation, who needs to work where, and hence our Mind the Gap report. We believe interprofessional practice is a must, in fact, so much so that we have initiated coalitions with other health professionals. We have a VPG on interprofessional practice, but we believe interprofessional practice is more than just having coffee and getting along. It's really respect the knowledge base of everyone. We believe full and expanded scope of practice is a must, and as you know, the government took up our recommendation for independent RN prescribing, and in fact that is moving forward, and the minister announced it at our AGM, and we are very involved, of course, on that. And I don't need to share with you that evidence-based practice, both for practice and policy, is foundational to us, hence our large program on BPGs, but also if you read a single report, whether it's Primary Solutions, Mind the Gap, or ECHO, is based on evidence. That is what will bring us to optimal health outcomes, not cutting short health professionals. And when we do all these 4 pillars, the deeper and the better we do them, we will get to health system effectiveness. Let's move, Josephine, to questions, if you can read some, please. And we will give it 5–10 minutes, and then we will move to Daniel, Joanne, and Sheena.
Okay, great. So our first question is, how will the pay disparities between CCAC, LIN, care coordinators, and their fellow nurses in primary care be addressed?
That is an excellent question, and a question that has been asked from us in the past several years. Our answer has been consistent. The care coordinators of CCAC will look at the most complex of all patients, and we have absolutely every intention to maintain their compensation and respect, and that is why we are saying they need to be employed at this point by the LINs. Where the issue of the fellow primary care providers, especially nurses, comes to play, and this is not only RNs, by the way, this is also RPNs and nurse practitioners, is that first we took a step, as you know, on the primary care nurse practitioner, and we were very successful in that endeavor, and the government is moving with improving, not to the level that we want, and we will keep pushing, let me assure NPs on the line, but we'll improve both the compensation in terms of salary and benefits for nurse practitioners. Where the compensation for RNs will improve is when the expanded role becomes utilized for those of you that will take on the additional education that will be required for RN prescribing and will really put forth a very robust and rich role. We will feel very comfortable and confident because we have been saying to government that primary care, both RNs and NP and RPNs, now that we move progress with NPs, are also underpaid and, quite frankly, underutilized. So we need to utilize fully RNs and RPNs in primary care, and we will then go for the compensation. Thank you so much for your question.
Okay. Our next question is, who would supervise the care coordinators in their primary care settings?
So that's a really great question, and in fact, we actually tackled that on page 22 in our response to Patients First, and again, this was something that we arrived at in consultation with CCAC care coordinators, and that involves designating a clinical lead in the primary care organization or potentially the sub-LIN region who can monitor caseloads as well as scoring for care coordinators.
Our next question, can you clarify and expand on the point on executives of CCACs not being transferred under LINs?
Yes, I will clarify, and it's exactly what says there. We have been very, very strong in communicating to all levels of government, from Premier's office to Minister to Deputy, that it would be an error in judgment to transfer all the CEOs of the CCACs directly into the LINs, because, first of all, the role of the LINs will change, and it will be inappropriate to transfer all that layer, which is extremely costly, as you know, directly into the LINs rather than have them apply to positions and take those that meet the requirements. Second, we believe that the system needs to focus on what the system needs, not only on the moving people from one chair to another. according to what's the health system transformation agenda. So that's what we mean, and we stand by that, and if someone wants to speak with us more about that, I will be absolutely delighted to do that. There is no doubt that the knowledge of the CCAC senior executives is important. The question is the fit for the transformed health system, and are they all needed, or what's the process to actually take those that are needed, and others will, for sure find opportunities for contribution in other ways.
How do you see hooking up patients who do not have a primary care provider?
So let me first share that there are fewer patients that don't have primary care providers as compared to years ago, so that's good news for Ontario. But certainly there are. We believe that it depends which population we are speaking about. If you're speaking, for example, about homeless people, we need to go to them, not expect that they will come necessarily to us. And there are many, many ways to do that through nurse practitioners, through RNs with expanded role, through bringing primary care to the streets, much as public health nurses, and in some instances home care nurses do, for example, St. Elise, with whom I buddy, to go into such visits in the street a couple of months ago, etc. There are also other issues that we are looking, for example, shelters. We believe we need to bring primary care to shelters, and the role of RN with expanded scope will be fantastic for that, as well as nurse practitioners in primary care. And then the issue that is more serious to us is how do we hook patients that have primary care with solo doctors today, but really when that physician is absent, do not have access to primary care and ends up in a walk-in clinic, which is not the best, or in an emergency room. And that's where we are saying that we need to link them to an interprofessional primary care site that subcontracts with that solo doctor.
So I think now, just in the interest of time, I'm going to turn things over to Daniel Lau, but that being said, we are paying close attention to the questions that are coming in, and we will maintain a collection of those, and we will find a way to respond to each of them.
Very good.
Okay.
Daniel.
Hello, everybody. My name is Daniel Lau, Director of Membership and Services. Now, also in the interest of time, too, I will be speaking at a very high level. If Josephine can advance the slide flyer. I'll primarily just use that to talk about membership. Many of us know that AO is the professional association representing registered nurses, practitioners, students in Ontario. We are a strong voice of 41,000 members speaking out for health and nursing. We help nurses to be part of the process that shape healthcare, nursing, and healthcare policy. So many members told us that that's one of the most important benefits that they value. Now, part of the membership benefits is professional liability protection, and the PLP that RNAO offers satisfies the CNO's PLP requirement. Right now, we have a very special offer for colleagues who are not already members of RNAO to join or renew their membership. They can join now, get up to months of membership, the price of 12. So join and renew now for the 2016-2017 membership year, and you can get the rest of the membership year, which is like 3 additional months for free.
I think you may want to remind people how much is the membership, Daniel.
Okay, thank you, Doris. Like membership, the regular fees is $256.36 per year, but for those who join, one or both of Shanique or OFPN, your membership fee can be reduced to $221.49. If you belong to owner,
which most of them do.
Right, yeah, your membership fee is $175 a year, and you get PLP, and you have 3 additional months of membership now, so this is like really a good opportunity.
So we are saying, just so I understand myself, $170 for care coordinators, which most of them are, in fact, all ONA members, for 15 months.
Correct. Yes.
Okay, with PLP included.
Correct, yes.
Fantastic. So, go to the lines today is my recommendation to you, colleagues.
Yes, to join us, you can go online, myrnao.ca/join, or call us at 1-800-268-7199. Okay.
Also members of OPSU get that discount, by the way. So if you are not ONA but you are OPSU and QP, also you get that discount. Very good. Next one, Shanique. Joanne, would you mind sharing about Shanique and the fantastic work of Shanique, please?
Okay, can you move it to the next slide? Great. Thanks a lot for inviting me to share some information about our organization. Can you hear me clearly?
Yes,
yes.
I can.
Okay. So the Community Health Nurses Initiative Group is a special interest group of RNAO, and we've been going strong for 35 years. For some of you, information I'll be presenting is not new, but it will give you an overview, while for others this will give you just a general brief overview of our organization, and perhaps you'd like to inquire further later. We're a dedicated board of 14 members with 2 to 3 student affiliate members that represent public health, home health, and other health and education sectors. Our board of directors volunteers their time and expertise to provide advocacy, leadership for community health nursing in Ontario. Our mission is to be the voice of community health nurses to influence healthcare system and health and policy, social policy in situations that affect the work of community health nurses and the public. In particular, with the impending healthcare reform, we're trying to keep abreast of the current issues to ensure that community health nurses are well represented. So as for our goals, as you can see by the slide, we have 5 key goals. And the objective of the first goal, which is to influence the health and social policies, includes advocating for the development of healthy public policy, for example, consultation with RNAO and other policies such as the Assisted Dying Bill. In Ontario, the consulting on and responding to policies that impact community health nursing practice. For the second goal of building capacity and leadership in community health nurses, our board aims to meet the objectives of creating opportunities for community health nurses to participate in professional development. So we provide professional development opportunities through webinars. We also promote uptake of evidence-based practice, which aligns with the promoting the BPGs. And we also promote and support CHN specialty certification with Canadian Nurses Association. So we try to disseminate relevant information regarding study groups or other links to certification information. The third goal, for strengthening the profile of community health nurses, we define and communicate the diverse roles through our undergraduate programs through the earliest with nursing students. We promote the value of CHN practice, for example, advocating at events to reinforce the importance of the role to the health of communities throughout Ontario. We also engage in social media to improve the community health nurses' visibility and public engagement. So, for example, we keep up to date on relevant information going on at a provincial level, as well as that's all relevant community health nurses posted on our website, as well as our Facebook and Twitter page. For the fourth goal, we promote, engage, and maximize membership. So we recruit and retain members in CNIG in order to meet the RNAO membership target and we do this through collaboration and dissemination through our newsletter as well as website. We identify and respond to the needs of Shanique members, so that's through emails as well as through conducting surveys. We offer bursaries and awards to members. And the final goal for encouraging and maximizing student involvement is by engaging interested nursing students in Shanique and CHN. So we try to support them to attend RNAO AGMs, as well as our National Canadian Community Health Conference. We also, by having affiliate members on our board, and more recently we've developed a subcommittee made up of students to plan for future student engagement activities. And lastly, we also try to influence schools of nursing to incorporate the competencies, concepts in the curriculum, and try to work with CASNs to ensure there's appropriate provincial or appropriate clinical placement. So to summarize, the Shanique membership provides opportunities for professional development through attendance education or our national conference, and to network and meet other CHNs in similar practice settings, to join our professional practice committees with public health and home health when CHNs, can share relevant and current issues with each other, and also to apply for awards and bursaries for education, research, or to participate in RNAO annual or Shanique annual AGM or the national conference. And lastly, to continue to
I will need to ask now that we let Sheena.
Yep, I'm done. Thank you very much. Visit our website, please.
And let me tell you that Shanique also, I think a very important point to mention, Shanique and other interest groups represent RNAO at key government committees. For example, breastfeeding, we had 3 members of Shanique, 2 members of Shanique, 1 of family practice nurses. Very, very important representation that they provide of RNAO. Sheena Howard, would you mind sharing about Ontario family practice nurses?
Thank you very much, Doris. Can everybody hear me?
Yes, we can.
Excellent. So good afternoon, and I'm here to talk about the Ontario Family Practice Nurses. The mission of the Ontario Family Practice Nurses is to support and promote, support and promote the professional role of registered nurses in family practice. As you can see, we have a number of objectives, and given the time, I'll let you take a look at this, but I'd like to talk about specifically about promoting the quality of primary care nursing. We provide mechanisms for exchange of knowledge and information. We also are providing a forum for networking for primary care, and also acting as a nurse resource for individuals, groups, and governments on issues concerning primary care. One of the things that we're most proud of was the engagement with RNAO and the Primary Solutions for Primary Care, as well as the institute that happened as a result.
So Sheena is talking about 3 institutes we did on primary care for primary care nurses with funding from government that OFPN was heavily involved with us on that.
That's right. Historically, OFPN has been involved with providing educational opportunities for nurses in family practice and primary care, and we're currently moving towards a direction for the future of the Ontario Family Practice Nurses. We're really excited about creating links with Shanique, also supporting the role of the RNs currently working in primary care to full scope, and we're also beginning our retreat to discuss realigning the image of RNs in primary care by moving forward with a name change in consultation with our membership to reflect the current political discourse, so specifically looking at the Ontario Primary Care Nurses Interest Group rather than in family practice. We're also moving towards increasing public awareness of primary care nurses as the anchor of primary health care. If you'd like more information, you can visit us at www.ofpn.ca and, of course, on Twitter at #PrimaryCareNurses. I'd like to stress the importance of Shanique and OFPN working together, and I would encourage members to join both of us as we move into this new transition in primary health care in Ontario.
Thank you, both of you, Joanne and Sheena. And the indication that over 150 people remain tells me that some of you likely are not members of RNAO, let me stress the importance of you joining the association, not only the impact that we have on health policy and nursing policy is huge, but also what the interest group offer, both Ontario Family Practice nurses as well as Shanique and other interest group, is critical to the feeling of community, the influence, and the engagement. So I will open for questions if we have a minute, or if we have a minute and people have questions. Otherwise, let me tell you that we will for sure do another webinar. We will shrink the presentation significantly, and then those questions that we didn't answer today will be the first ones that we will answer. So for those of you that didn't get your questions answered, be assured your questions will go first next time. And I so much appreciate with my colleagues here and on the phone. Over 200 of you join and over 150 stay. Hopefully we will see you as a part of the NAO family. Yes, please.
Okay. How would long-term care applications be managed? Would the CCAC care coordinators in community or hospital under the LHIN continue to manage these?
First of all, CCACs will not be there as an entity. So what we believe in terms of our NAO is that the LHINs will manage the overall long-term care file to see the number of beds in the region sufficient, et cetera, Our NAO would prefer that the primary care site, in collaboration between the care coordinator located in primary care employed by the LHIN, be the person that communicates with the person that is ready to move to a long-term care facility with their family to really see the best location for that individual so it fits their needs and the family needs. And that care coordinator working in the interprofessional team will have the in-depth knowledge of the relationship with the individual and their needs.
Question. What are the visions for the patient and family councils? Are we reframing existing ones or are we creating new ones?
Well, right now there is not much of patient family councils in all the LHINs, or sub-LHINs for sure, because sub-LHINs just began a couple of years ago. So we see those really more local. We see them consistently everywhere. The government has not announced such an entity, although they did announce a patient ombudsman, that is Christine Elliott, and it is in the HQO. In Bill 210, there is the formation.
So in Bill 210, there is the requirement to establish patient and family advisory committees.
Committees, okay. Fantastic. So here you go. I missed that, and it's fantastic that we have them. So we influence that as well. The question will be if it's enough in the LHINs or sub-LHINs, but time will tell that.
With the system changes, how will they ensure consistency across all the LHINs? Some LHINs have ex-CCAC nursing clinics while others do not.
We believe, first of all, again, CCACs will not be there, and right now that's one of the problems. You said some LHINs have this, some LHINs have that. What we are recommending is that there be consistency on the LHINs. That's why we also want the LHINs not to get into service delivery, but actually into planning. We believe the conductor of the orchestra is the government and the Minister of Health, and that's why we have a Minister of Health. And in fact, the legislation has new parameters for the minister, that the minister can intervene and can direct LHINs to do ABC if the minister deems that appropriate. So that is a prerogative of the minister in Bill 210 that it was not before. In addition, Tim shared with you the fabulous diagram, but also there is a role description that we have developed for primary care coordinators, and we did this with the hope that it will provide more consistency.
Please discuss how placing CCAC NPs with service provider agencies could be beneficial. In my opinion, making the work that NPs do a business does not seem to fit with the patient's first model.
So Not sure what it means the work of NPs do a business. Quite the opposite. We believe that anchoring the NPs within home care, within public health, within primary care, within long-term care, as we now have attending NPs in long-term care, in fact makes the role of the NPs so much more valuable because they become part of the life of those patients, those residents, and those interprofessional teams. So it's much less than what is happening now, that they are centralized and only sent when there is a need. So I would really appreciate the colleague that sent the question to connect with us, because maybe we're not fully grasping the question, but I'd like to discuss it further if you think there is a need.
When you say that there will be a set of standards for care coordinators, will that be a specific designation, and will it require the case coordinator to be a healthcare provider?
Of course.
So in terms of the standards for care coordination, in terms of it being a specific designation, or does it need to be a healthcare provider? So yes, we do feel that it needs to be a regulated healthcare provider who offers that service. Specifically, we feel that RNs have the competencies to be able to thrive as care coordinators because of the knowledge, skills, and competencies in health service delivery, anatomy, physiology, pharmacology, and then juxtaposed to that, knowledge of the structure of the healthcare system and transitions in care and how to facilitate the most effective transitions, as well as a close understanding and appreciation. So that being said, we do feel that RNs are uniquely able to thrive within this regard. And so we see that it would be the care coordinators from CCACs that would be providing service to those who have the most complex needs, and then existing RNs within primary care would be providing care coordination to the balance of the population that has varying levels of complexity over the course of their lifetime. We do, within ACO, acknowledge that there are currently other health providers who are serving in the care coordinator role, and we would see those providers as well transitioning into primary care. So by no means have we forgotten about them, but I really do want to emphasize the opportunity here to recognize the very unique contributions that RNs have simply by the way that we've been educated and our scope of practice. So hopefully that helps to answer that question.
To augment that in relationship to rehab professionals that serve in care coordination, we have also spoken in the ACO report, both ACO 1.0 and 2.0, that we believe that home care needs to be organized in a way that if I need home care, I don't see 5 different agencies coming to my house, but that home care agencies provide the 24/7 of all necessary needs, including rehab needs where possible. So our colleagues that are from rehab disciplines may also find it very important in relationship to the link between primary care and home care, which is, by the way, one of the weak links in the system, the link between primary care and home care, and a recent report of HQO pointed to that.
Clients in the community have expressed concern that they will no longer be serviced. I have been reinforcing that care will be delivered as usual, but it is more a change in who employs the care coordinators, where they work from, but the changes are more in the background. Would you suggest any different response be provided to patients?
I think that that's a fantastic response, and my colleagues are nodding here, a fabulous response. I would perhaps only add that in our view, the service not only will continue to be delivered, but will be stronger because it will be aligned with the primary care providers that already are attending to that individual. So it's one less step, so to speak, and more integration. So hopefully the person will experience higher integration and better health system navigation when needed.
Does RNAO support resource allocation to equip physical facilities for care coordinators to be placed in primary practice offices?
Yes, we do, and there are significant challenges in some of the primary care offices in terms of not having enough space for the care coordinators. We believe that that needs to be adjusted. We believe that is essential. It is not possible that other people have their own office and care coordinators will not, so absolutely we are pushing for that.
And I would add to that as well, though, completely support what Doris has said, but first doing an assessment to understand what capacity currently exists within primary care, because there are some primary care settings who do have the space ready to go, and then to identify what expansions are needed after that assessment has been done.
By deploying care coordinators to community settings, how will this impact the role of contracted service agency care coordinators in order to reduce duplication of LIN-employed care coordinator and contracted service provider agency coordinators?
Not sure what contracted service agency coordinators means. We believe that there ought to be a care coordinator and that person is located in primary care, employed by the LIN not to disrupt their employment relation and compensation agreements, but that they should be located in primary care. That care coordinator communicates directly with the patient. That care coordinator communicates where there is a need with the discharge planner in the hospital. That care coordinator triggers when there is a need, home health care services, or communicates with long-term care. We do not believe that you need layers over layers of care coordination in home care. In fact, that from the outset of the creation of the CCACs, our colleagues in home health care experienced significant challenges in terms of they believing that the patient needed X number of visits, but the CCAC care coordinator mandated by their employer believed that they needed to restrain the visits. We believe that that care coordination is negotiated by the care coordinator with the patient, with the family, with the home care agency, if that's what's needed, or long-term care, etc. Furthermore, we don't believe in the type of rules that today we have. For example, a person at the end of life, 15 weeks, that's what you get. Maybe one person wants nobody coming from their homes to their home because they have family, friends, colleagues, etc. Maybe another person needs 20 weeks. We believe that that's a critical role for the care coordination, the patient and their family or other caregivers to coordinate.
We've also recognized in ECHO that there may be times where a person's needs necessitate a specialized care coordinator. So, for example, in the cases of some instances where a person has cancer, not all people are going to need a specialized care coordinator, but in that case, it may be appropriate. Now, that being said, this really, I think, would be more of the exception rather than the norm, and that specialized care coordinator would feed back into primary care. And then again, continuing to recognize and acknowledge that primary care is that center of coordination. It is the anchor, and that everything would feed back into it.
And that, if you look at the slide 10, where we show the diagram, is the specialty care that the team is referring. And by the way, one of the areas of concern of primary care is that specialty care, right now at least, not always is communicating back to primary care. So the primary care provider, being that an RN or a nurse practitioner or a family doctor or other discipline, really don't know what's going on except through the patient, and sometimes missing on aspects of that person's needs.
What can we expect as hospital care coordinators? Currently, there are 6 coordinators in my hospital. What changes can we foresee?
So it is my understanding from government and others that currently you will continue to be hired and compensated, I know that the compensation is half through the lien, half through the hospital right now. We believe that that will not change for the time being. We would like to see you in the go forward employed by the hospital like our previous care discharge planners, so that you are fully part of that organization. But right now you shouldn't expect much changes, is my understanding.
How do you foresee CCAC client care coordinators potentially impacting currently employed RNs in the role of non-unionized system navigators in family health teams in rural areas of Ontario?
So I think that we've already answered this question. So the current CCAC care coordinators would be employed by the LHIN, located within primary care, and would be coordinating service for those who have the most complex needs. And those RNs already within primary care will stay in primary care, and they will be coordinating service for the balance of the population. So for those who have perhaps varying levels of complexity across their lifetime, they have something that happens along their illness health journey, and they require, 4 or 5 months of care coordination. That would be the existing RNs within primary care. And also being able to continue to support and provide assistance to keeping people well in the first place so that they don't become ill. And that's, I think, an important role in terms of health promotion of both the existing RNs within primary care as well as the care coordinators. I think that's an overarching goal.
So I will ask you to attend the next webinar. We will send you dates simply because we have 40 additional questions. I will urge you, those of you that are not RNAO members, to go to www.rnao.ca, www.rnao.ca, or call 1-800-268-7199, 1-800-268-7199, and let me assure you, you will get 15 months for $175 if you are an ONA or a, did I say wrong?
The ONA, yeah.
If you are an ONA member, and about 200 and something if you are not with the interest groups. It is imperative that you join. It includes your professional liability protection, which, by the way, is firm, is an insurance, and is very, very strong. So call 1-800-268-7199 or go to www.rnao.ca, and we hope to see you at future webinars, whether on the same topic or different topics, which are always posted on the website and in the loop. For those of you that will join today or tomorrow, we will ensure that you also get the latest in the loop that went out on Friday with new great opportunities of positions at RNAO and also new initiatives that we are moving forward. Thank you so very much, and thank you, Sheena and Joanne from Ontario Family Practice Nurses and Shanique. You are doing a tremendous to the profession and to your interest groups, and your presentations were fantastic. I'm sorry that the time didn't allow us for more. We will make sure that next time we expand the time for the presentation. Thank you, Daniel.
Thank you so much, Doris.
And Josephine.